Once again, good afternoon, everyone. Today's session, I'll be dealing with the intoxications. The outline would be a brief introduction about it, a definition, current prevalence, and various substance intoxication like alcohol, opioid, cannabis, stimulant, and briefly about solvent and hallucinations. And in general, how to approach a patient with an uh, intoxication and also a severe form of comatose patient. Uh, there has been a recent use as well as availability of psychoactive substances all over, and there has been a rise of its prevalence. And frequently, a drug is taken in order to achieve a desired degree of intoxication. And secondly to it, the effects can be mild, moderate, severe, and some cases even life-threatening. Substances or the drugs toxicity. This has been found to be identified among both new users as well as regular users. So the common one of the common reason for emergency department visit. So out of this four, like intoxication or overdose, commonly for withdrawal, accidental or injuries, secondary to substance use, or secondary complications, which could be medical or psychiatric. And intoxication is also one of the common reason for medical attention. Many of the drug-related deaths occurring in emergency services involve the use of substances, and most of the times it's polysubstances together. Coming to the definition, intoxication is a transient condition and which follows following administration of a psychoactive substance, and it results in disturbance in level of consciousness, cognition, perception, judgment, affect, or behavior, or other psychophysiological functions and responses. And the characteristic features of an intoxication would be disturbances related to specific substance, is the acute pharmacological effects of that particular substance, and in general over a long period of time a learned response to a frequent use of the substance, and it's usually a transient, and over a period of time it resolves, and usually there is a complete recovery except in certain situation where there is a damage to a tissue or other complications arising secondary to the substance use. But it's not always that a pharmacological action. There can be the other way around also. For example, when depressant drugs are used, it's not always a calming or drowsiness noted. A paradoxical agitation or hyperactivity can be seen, in particular to depressant drugs like benzodiazepine or alcohol. Similarly, a stimulant drug can cause occasionally socially withdrawn and introverted behavior. And sometimes the effects are not in range of the physiological functions. It can be unpredictable in cases of cannabis and hallucinogens. And the effects are usually the reversible of primary action in different stages of substance use, like in early stages of intoxication and then subsequently severe intoxication, or during the withdrawal phases. For example, activating the drugs which are activating during intoxications, like amphetamine, cocaine, MDMA, they can have a sedating during the withdrawal. So it's a reversible of the intoxicating effect. Similarly, sedating drugs can have an activating influence during the withdrawal symptoms. Now, acute intoxication is dependent on various factors, which includes the gender, the weight, age. Like in gender, the quantity required or the amount required may be lesser in case of women when compared to men. And again, weight, there's depending on the body water distribution. Age, younger age and the elderly, the dose required is relatively lesser. It depends on the general state of the health. Like when associated with other medical comorbidities, the amount required is lesser to cause intoxication. Again, the type of substance or the concentration of the active molecule in the substance, dose of a drug, as well as frequency, how frequently it is used, and as well as absorption and elimination rates. Again, similarly, in case of a liver problem or other organ failures, the elimination rate may be delayed and then causing to an accumulation effect. Or the mode of use, sometimes they're used directly or mixed with certain food or a drink, other drink like soda and all, which have an effect on absorption, thereby leading to a rapid rise in the blood levels or a gradual rise. And as I said again, the impact of the medications and food intake on the absorption and the elimination. And again, individual's level of tolerance. A person who has been newly introduced to the substance might get intoxicated at a very low dose and earlier stages, whereas a person who has been using substance for a very long time who has developed a relatively high tolerance might require a relatively much higher doses to attain that intoxicated state. And lastly, a social context too acts as a factor in causing intoxication, depending on the situation where he's around. Uh, for example, in the parties or in situation like in when he's sitting alone, so that that situation itself can have an impact on causing intoxication. Uh, and most importantly, behavioral expression of a given level of intoxication is strongly influenced by the cultural and personal expectations. Like there might be a different level of expectations from a different cultural background. So some tolerant cultural backgrounds, the level is required is relatively higher, whereas in certain cultures where even a small drinking alcohol itself is a ban. So in such situation, even a low dose could lead to a ill effect. And exception to some of the cases where, as I said, underlying organic conditions or renal or hepatic insufficiency. In these situations, even a very small dose would actually cause an impact which otherwise would have not caused. So there are various psychoactive substances which can cause intoxication. So this includes alcohol, narcotics, cannabis, stimulants, and others like sedatives, hypnotics. And related this, nicotine is generally is taken out of intoxication classification and is believed to be not causing intoxication. There are very limited studies on actual prevalence of intoxication per se and available services they require. But considering from the various studies, generally around 10 to 40% of the emergency department visits are secondary to substance related, and majority of them are related to alcohol. And a few of the studies which says 1.2% in particular only to alcohol intoxication, taking away from the other secondary effects of withdrawal or delirious cases. Only intoxication, it was 1.2%. But whereas the other substances, there's a very sparse data, and I couldn't find an exact prevalence per se. Moving on to particular individual substances, the common being alcohol. It's a commonly used illicit substance worldwide. Of course, being the tobacco is the first, and the other one available, alcohol. And as I said, there's a varied range of presentations as well as problems from minimal, like a minor, simple to a complex or even to a life-threatening presentations. Intoxication by alcohol is quite diverse and it depends on various factors. Like discussed earlier, it depends on the amount of alcohol taken, the rate of the use, and what type of the use, depending on the situation and surroundings, quantity, and the duration. So depending on the various blood levels too, you tend to have a different effects. Like for example, 20 to 30% of the blood alcohol level, this is usually a slowed motor performance and decreased thinking ability. And as the percentage increases from 30 to 80, there is increase in motor cognitive problems. And 80 to 200, a further increase in incoordination and judgment errors, mood liabilities, and cognitive deteriorations. Further higher will lead to further worsening of the same symptoms, as well as nystagmus, marks blurring, and even amnesias are noticed. And more than 300, there's a literally a serious form with impaired vital signs and possible death. The currently for the Indian legal standards, 30 is the minimum required for, or less than 30 is allowed in the Motor Vehicle Act, whereas in Western it is somewhere around 80 percentage. Going to the effects, for a intoxication to happen or to come to a conclusion of intoxication, the first and important criteria is it has to be of a recent use, and second to the recent use, there has to be some mental and behavioral disturbances and some physical signs. So with respect to alcohol, some of the important ones are impaired attention and judgment, whereas in the physical signs, it's either one or two of slurred speech, incoordination, unsteady gait, nystagmus, and in the severe form, we go into stuporous or coma. In addition, you find other findings. In most of the intoxicated patients, you tend to come across the impaired judgment, social conduct, occupational function, and mood liability. But in particular, the distinguishing features for alcohol includes these things. So in general, in brief, the treatment would be symptomatic and multivitamins and supportive management. Um, and in case of severe intoxication or comatose patient, where the commonly reducing the absorption is one commonly method used. Alcohol is not generally absorbed by activated charcoal, so this method cannot be used. And since the elimination rate is very slow, 10 to 30 milligram per hour, is generally a proper symptomatic supportive care is required. And preserving the respiratory and cardiovascular functions has to be taken care. If there is a generally you come across a lot of agitation in these patients, so non-pharmacologically supportive interpersonal in the nursing approaches, trying to de-escalate with the interaction. If the situation is intense, we can use antipsychotic medications at a low dose, say haloperidol 5 milligrams, IV or IM can be given. And if there is a severe form going into comatose or stupor, and you need to identify some other factors which are commonly associated with these patients, like metabolic disturbances or head injury. And regarding the management of coma cases, I'll be discussing it later. Moving on to the atypical form of intoxication, also called as idiosyncratic alcohol intoxication. Here we tend to find a severe behavioral syndrome in a very small amount, which otherwise, if a normal person had taken, has no or minimal effects after taking that amount. The cause is not clearly known, but it's commonly seen in people who are pre-anxious before taking the substance, or second due to some organic injury to brain like post-encephalitis, etc. It's usually dangerous to self or to others. And one important thing to know about this condition is it has a diagnostic importance in forensic arena. Like whereas other alcohol intoxication, the person is held responsible for his or his acts, whereas in idiosyncratic alcohol intoxication, claim on the insanity is permissible. Again, the features include patient is often found confused, disoriented, and they may have perceptual disturbances, transient delusions, and increased psychomotor activity, aggression, and impulsive. It's usually a short lasting and terminates by sleep, and following awakening, it's associated with amnesia for that certain period. Treatment is generally a supportive care and calm surrounding, preventing care from injuring to self or to others. Again, in this, if there is a patient is restless, haloperidol injections can be considered. Moving to next substance is opioid. Again, the intoxication and management depends on the severity of the intoxication. Generally, in mild to moderate cases, specific treatment is usually not necessary, but overdose should be considered in the presence of some cardinal features of opioid, like meiosis, like pinpoint pupil, bradycardia, severe respiratory depression, stupor, or coma. Any of these features, high suspicion of opioid intoxication should be considered. Whereas other features, what is commonly seen is, again, in general, mental and behavioral effects, which includes impaired judgment, impaired social occupational functioning, impulsivity. But the features which are very much related to or cardinal to this substance is drowsiness and impaired attention and memory, same as alcohol. But whereas in physical signs, it's usually pupillary constriction, but it can be dilated in a severe or overdoses secondary to anorexia to the brain. And addition, slurred speech and severe form, stupor or coma. Other physical signs include slow respiration, slow pulse, dryness in mouth or nose, or slow gastrointestinal activity. The treatment here again is supportive and symptomatic. In severe forms, naloxone antidote can be used. Lower doses are used in patients who are addicted to opiates because higher doses, there is a high chance of putting the patient into withdrawal. But when there is a CNS depression, but no respiratory depression, the dose required is relatively less. The recommended is 0.05 to 0.4 milligrams IV or subcutaneous. And if there is a severe respiratory depression, the initial dose could be starting with 0.4 and then increase it to 2 milligrams. If there is still no response, the doses can be repeated every 3 to 5 minutes to the maximum of 10 milligrams. Usually the effect lasts somewhere around 2 to 4 hours. And but if you find that there is an improvement but not enough improvement, the doses has to be continued for 24 to 48 hours if a person is found to be using a substance like heroin with a smaller, shorter half-life. And if they're using a longer half-life drugs like spasmopoxygon, tramadol, or methadone, in such cases, the duration of continuous naloxone use is prolonged up to 72 hours. Usually, the dose required is two-thirds of the maximum dose, like that's somewhere around 6 to 8 milligrams over a period of time, and then gradually take it off. To the third substance, this is the most used illicit substance worldwide. Again, the rate of intoxication depends on what type of the substance you are taking and what route is used. And generally, smoking leads to a faster intoxication than oral because of the rapid absorption. And again, in this intoxication, the surrounding environment and the underlying mood plays a major role. This patient, the presence of anxiety symptoms are one of the common reason why cannabis intoxicated people seek treatment. And again, aggressive behaviors are very common in patients, and this is generally due to the effect like a distorted perception of reality or reality. The effects, again, which are very typical to or confined to this cannabis is a lot of anxiety, paranoia, perceptual disturbances, and importantly, time distortion. Whereas in physical signs, very typically you come across red eyes or congestion, dry mouth, thirst, and again increased appetite. Pulse rate, either they can be increased or decreased. In addition, there will be impaired judgment, impulsivity, aggressive behavior, again impaired attention and memory, and impaired social occupational functioning. Management would be again primarily symptomatic on benzodiazepines, and in case if there is a aggressiveness or psychotic symptoms, go for a low dose of antipsychotics like haloperidol or olanzapine injections. Coming to the stimulant group of medication, these are again use and availability is currently on a rise, and usually they used in a binge pattern, and you don't get a dependence or regular users. There's a period of binging and then off periods. The adverse effects, again in this scenario also, there will be mild symptoms. It ranges from mild symptoms to life-threatening toxicity, and toxicity generally noted among new users and as well as in a regular users. The features here, you get a lot of a sympathetic overactivity, like in the form of tachycardia, or pupillar dilatation, perspiration, nausea, vomiting. But again, the features which are very cardinal to this are in the severe form can be muscle weakness, chest pain, or cardiac arrhythmia. It might mimic like an acute MI, and there's something called as excited delirium in intoxication state, which can be seen with more commonly with the stimulant. Although it is deliriums are seen in alcohol and cannabis intoxications too, but very commonly noted in stimulant intoxications. And another motor symptom you come across in stimulants is dyskinetic or dystonic movements. And in addition, persecutory delusions may occur in the intoxicated phase. Management, again, like intoxication, usually these are self-limited and requires only monitoring and support interventions. Whereas if there's agitation of psychosis, low dose benzodiazepines and neuroleptics can be used, like haloperidol. One thing which is important to be noted in cocaine or stimulant intoxication is whenever they present a precardiac pain, it's usually associated with acute myocardial infarction like presentation, and you need an intense evaluation like going through echo, complete blood picture, and getting a CPK-MB levels. Because of the increased sympathetic activity, they are known to precipitate cardiac complications. Whereas in this case, if there is a high dose gastric lavage can be used, and activated charcoal is found to be useful in only in this group of substance overdose, provided the use of activated charcoal is within 30 minutes of intake. And one again, as I said, MIs are very common because of the increased sympathetic activity, secondary to again raised hypertension. Beta blockers are inspecific to be avoided because it can cause a paradoxical further increase in BP and then worsening, causing MI. Brief about solvents. These are commonly others terms used are volatile substances and solvent. Basically, a volatile substance means when the moment they are exposed to the environment, they get evaporated. Most commonly used by children and adolescents, and generally these are the first drugs used in young people. And toluene is one of the most common constituent of these solvents. Routinely, they use by inhalation through nose or in the form of bagging through mouth. Commonly found in household products like whitener or erasers or paint thinners, etc. Like the common commercial available are solvents in the form of glues and adhesives routinely used, propellants like aerosol paint spray, hairspray, shaving creams, and thinners, paint products and correction fluids, and fuels like gasoline and propane. Commonly which are abused in India are ink eraser fluids and correction fluids, followed by petrol and then adhesive glue. Approximately around 15 to 20 breaths of say 1% gasoline, it leads to several routinely intoxication can last up to 20 to 30 minutes, but in the high concentrated solvent, it can last up to 3 to 4 hours. Here again, depending on the severity of the intoxication, the symptoms can be like in moderate headaches, dizziness, disorientation, ataxic, and in strong intoxication, it can cause blurred vision, nausea, vomiting. Again, more severe form, you can have an auditory and visual hallucinations and distortions of body image, delirium, and second to this, they might get aggressive and violent behavior, and rarely seizures are noted. Again, management remains just to observe. It usually resolves spontaneously, mainly to reassure and keep a quiet and supportive environment. Attention to vital signs and levels of consciousness has to be monitored. In emergency situations like coma, bronchospasm, arrhythmias, which are commonly seen with this patient, you need to give a emergency care. And one thing to be careful in these patients are during intoxication, try to avoid a confrontation or see to that the patient is not agitated, because the ones in intoxication, agitation can lead into severe cardiac complications in the form of arrhythmia or even cardiac arrest. But again, if there is unmanageable aggressiveness, haloperidol can be used. Preferably avoid benzodiazepine, as it is said that it might worsen psychosis, and again secondary to respiratory complications which are noted with this patient. Lastly, briefly about hallucinogens, also known as psychedelics or psychotomimetics. These are characterized by more of a psychotic symptoms in the form of hallucinations. In addition, loss of contact with reality, and they experience expansive and heightened consciousness. The common used are LSD and phencyclidine, also magic mushrooms, etc. These are all known as club drugs. The effects depends on the duration of its action. The initial few minutes, maybe half an hour, you get a dizziness sensation, lightheadedness, anxiety, nausea, and then over a period of 1 hour, physical symptoms in the form of blurred vision, pseudo hallucinations, which are more of a geometric and majestic imageries when they close the eyes, decreased concentration, depersonalization phenomenon, and over the 1 to 4 hours, the images become more intensified, and a rapid flood of emotions, which may include euphoria, again anxiety can happen, and over 4 to 12 hours, there is a gradual decline to the baseline. So this was in general about this was about particular substances. Now moving on to a general approach to any patient who is intoxicated. So the main aim of the management would be to stop or reduce the acute effects of the substance. But for that, there are general guidelines for treatment in an intoxicated patient. The first and foremost is to reduce the exposure to external stimuli, providing confidence, guidance, and reality testing in a safe and monitored environment. then investigating which substances he has used and what is the routes and what doses he has taken, time since the last dose, and whether the level of the blood level of the particular substance is either increasing or decreasing, and removing the substance from the surrounding, in particular from the contact, and reversing the effects of the substance, and lastly to stabilize the physical effects of the overdose. So this begins with a proper diagnosis, so which generally as a general principle, thorough psychiatric assessment in the form of detailed history from whatever available resources, maybe the patient if he is able to express, or the accompanying person, or the past records, based on the general physical and psychiatric examination and previous treatment histories. If no adequate information, then screening test, which can be in addition to it. A polykit can be drug, and complementary laboratory tests like alcohol biomarkers and other biochemical parameters, which can assist in coming to a diagnosis. And sometimes if there is no available information, certain clinical findings or severe symptoms can be a hint to suspect intoxications, like whenever there is a muscle rigidity, dystonia, cardiopulmonary arrest, hyper or hypotension, ventilatory failures, aspiration and bronchospasm, liver failure, renal failure, or rhabdomyolysis, and other metabolic parameters. So this also gives a hint that there could be a possibility of intoxication. And whenever an intoxicated person is generally believed to be a regular users in most of the cases, so background of his nutritional status, which could be a contributory or could help in management, should be kept, like malnutrition, infectious diseases, trauma, self-inflicted injuries. Usually this are more prone for aggressive and self injury as well as injury to some others, suicide. Because of the chronic use of the substances, they tend to have other medical comorbidities like oral cancer, lung cancer, liver cancer. So those things have to be kept in mind. And maternal and perinatal conditions, like situations of the earlier case. And lastly, cardiovascular diseases. So a rough guide would be based on the symptoms they present. Generally, most of the psychoactive substances, they are either depressant or stimulant. So if you look into sedatives, which includes benzodiazepine and alcohol, they commonly present with all the features suggestive of CNS depression in the form of drowsiness, and in the severe form going to confusion, stupor, or coma, and other associated findings, bradycardia, hypotension, hyporeflexia. Whereas in narcotics, as I said, the cardinal features being pupillary constriction, CNS depression, coma, and in addition bradycardia or hypothermia and respiratory depression. Whereas sympathomimetics like hallucinogens, like amphetamines and cocaine, they have more of sweating, tremors, anxiety, tachycardia, hypothermia, and pupillary dilatation. And hallucinogenic, more of hallucinations and depersonalization, agitation, classic features. And in addition, hypothermia, tachycardia, hypertension, nystagmus, etc. In general, when a patient is presenting, a rough guide would be to assess about his mood, to see whether he is calm or excited. But whenever he's calm, proceed to find out if there is psychotic symptoms or no psychotic symptoms. In this case, when there is no psychotic symptoms, assess the pupils. If it's constricted, look for the skin changes, whether there is a diaphoretic, warm and not flushed, then usually a sedative or tranquilizer intoxication is considered. Again, if it's dilated, only in the severe form, and if the skin is dry, warm and not flushed, opioids intoxication is considered. But in most of the cases, opioid intoxication is constricted pupil. But the skin changes are generally dry, warm and not flushed. If there are psychotic symptoms and a constricted pupil, on examining the skin, if there is a diaphoretic and warm and flushed, usually it's a stimulant withdrawal. But if the pupils are dilated and skin has dry, warm, flush, then possibility of stimulant intoxication. This is when the mood is calmer. When the mood is excited, then again you have to see whether it's psychotic or non-psychotic. If it's non-psychotic pupils, if they are dilated, It depends on the skin again. It's diaphoretic, more of a opioid withdrawal. If it's dryness, then a sedative withdrawal. If it's a constricted pupil and skin is dry, then a chronic stimulant withdrawal. In a psychotic patient, if the pupils are generally dilated and skin, if there is diaphoretic, the possibility are tranquilizer withdrawal, psychedelic intoxication, and if it is dry and warm, then acute stimulant intoxication. If again based on the physical symptoms, also there can be a certain clue of what possible substances they are taking. Like if there is a hypothermia, basically same as depressants like alcohol, barbiturates, and opioids are possible causative or intoxicant. If it is hypothermia, then sympathomimetics or like amphetamines and cocaine and LSD. Based on the pulse, if there is a tachycardia, then again cocaine, caffeine, alcohol, and if there is a bradycardia, it's depressants like opioids, sedatives. Alcohol can have, depending on the dose level, increased or decreased pulse rate. And pupil size is another clue. Constricted, then it's usually barbiturates, alcohol, and opioids. If it is dilated, or for sympathomimetics like amphetamines and cocaine. If they are based on the agitation or level of psychomotor activity, depressed, then alcohol, barbiturates, benzodiazepines, and opioids. If they are agitated, it can be alcohol, opioids, paradoxically, and sedatives and hypnotics, cannabis, cocaine, and caffeine intoxication too can cause an agitation. And delirium and confusion are generally seen with more commonly with alcohol and sedatives, and less common with opioid. Whereas seizures, alcohol is the common cause where there's a intoxication related seizures, followed by cocaine and opioid. And another classic feature which can not seen in other substances during intoxication is dyskinetic movements, which are very much particular to cocaine. That was approach to in general intoxicated patients. In the extreme form, for a comatose patient and its management, the first and foremost would be the ABC technique to look into his airways, ensure the patency of airways with precaution of cervical spine to be taken care, followed by breathing. Endotracheal tube, it's not always necessary unless if there is no spontaneous breathing or no cough or gag reflex, and supply with a simultaneous oxygen supply. And moving on to the circulation, first and foremost to be done is to have an IV line intact. Then generally most of the situation it's usually associated with hypertension, so blindly 1 unit of normal saline can be infused unless there is a specific conditions like cocaine, or whether BP is very high or there is no signs of dehydration, it can be avoided. And later on the coma cocktail, what is used is first and foremost to use a thymine injection, followed by dextrose, irrespective whether it's a diabetic or whether it's hypoglycemic. If there is a availability of to check the glucose levels, it can be checked. If it is normal, then need not give dextrose. And next is naloxone. So first foremost to give 0.2 to 0.4 milligrams IV, or if there is an endotracheal tube intact, it can be given through it. If there is no response in initial 2 to 3 minutes, it can be further repeated, like additional 1 to 2 milligrams, and this can happen. This can be repeated till the maximum dose of 10 milligrams. Even after that, if there is a no response, then it's unlikely to be an opioid toxicity. And as I was saying earlier, if it is opioid toxicity, then usually the effect lasts 1 to 4 hours, and repeated doses or continuous infusion is required in case of significant intoxication. And care should be taken if there is an acute pulmonary edema or opioid withdrawal and seizures have been reported with naloxone administration. And if there is no response with naloxone, the further possibility of considering benzodiazepine, where flumazenil is an antidote which should be considered. And precautions to be taken is, or there is a risk of precipitating seizures with flumazenil when there is a suspicion of benzodiazepine plus cyclic antidepressant overdose. And but otherwise, there are a lot of studies which is said even in such situations, flumazenil is relatively a safer drug. But however, Glasgow Coma scale score improves, but it does not appear to have a significant effect on cost or major diagnostic therapeutic interventions. But still, if you look at the cost effectiveness of routine use of clomazanil as part of the coma cocktail, still remains controversial, but definitely helpful in case if it is an acute benzodiazepine overdose. The doses would be initially zero point 0.2 milligram of IV given over a period of 15 seconds and followed reassessed after 1 minute, and a repeat of another 0.1 milligram can be considered till a maximum dose of 1 milligram, but certain situations it can go up till 3 milligrams, but beyond 3 milligrams generally do not provide any additional benefit, and the steps have to be taken for further care. In addition to this, other measures have to be taken, like prevention of absorption, like gastric lavage, MSs, and activated charcoal can be used, and bowel irrigation. But most of the psychoactive substances generally, these methods don't help except for in stimulants, and enhanced eliminations in the form of alkalizing and forced diuresis can be considered. In case of alcohol or severe hemodialysis or hemoperfusion is considered, and extracorporeal removal of toxins like hemodialysis and hemoperfusion is the other method. And in addition, the specific cause is known, then as I said, the specific antidotes can be used, like in case of methanol, ethanol and fomepizole or folic acid, opioid as you know naloxone, and if it's benzodiazepine, clomazanil, with respect to psychosubstances, active substances. And if there has been no revival even after all these efforts, then advanced ICU care is the next step. In generally, whenever these 8 conditions are there, then it is a need for ICU care. If there is a PSU2 of less than more than 45, and whenever there is a need for endotracheal intubation, and toxin-induced seizures, cardiac arrhythmias, or QRS duration of just 1.12 seconds, if the BP is less than 80 millimeters of mercury, second or third degree AV blocks, and if the patient is unresponsive and Glasgow Coma score is less than 12, then the patients require an advanced ICU care. Thank you.
Thank you, Dr. Veerappa, for that elaborate presentation. We will see if there are any clarifications from any of the partners elsewhere or anybody here.
Sir, I didn't get the point why naloxone, like I don't know, coma cocktail included even the. Is it for all or?
See, generally, when there is, you don't know what substance a person is taken, and is suspected of intoxication. So that's the protocol which is followed, because you don't know what substance is taken, and these are the certain life-threatening situation, and there are specific antidotes which can actually reverse the situations. So as a precautionary measure, it's taken. I mean, it's given, an naloxone is given, and by just if there is no response, it generally rules out the possibility of, and you can proceed further. This is generally to any intoxication, not only specific to substances, even to other medication overdoses, or even any unknown overdose.
There's a question in the chat by Dr. Zillu. Does horrifying experience of intoxication encourage the patient to quit substances?
I don't know exactly what it leads to, but most of the dependent patients tend to have intoxication experiences, but only the severe form of experiences probably might be, but we don't know. There's no evidence. I have not come across anything like that. But otherwise, the like alcohol dependent patients, in generally they have an intoxication experiences, but they keep drinking subsequently too. I have not come across any data of that.
There have been some studies with which have looked at taping experiences during intoxication and especially during withdrawal, eating, and trying to see whether that makes changes. Local results. That there was one study done at our center not really sure what the results were. Oh, what the results were.
That was because this one which was used was with, with actors and things like. There was no much difference in this protein. The study was not positive, but we cannot comment on it because it didn't have that personalized message for the patient per se. Generally, as you said, like there are many who do come with intoxication and this thing. Like there are people who come with others intoxication, OD, and finding them having seizures and all those things. They do come for treatment, but whether they start hating the substance is, I think.
No, but remember, when you're talking intoxication, you're not talking of dependence. And as you are aware that the new ICD-11 will have a
Substance-induced
category,
disorders.
yes, following a single exposure. So, I mean, when you're talking about young people who have had very bad experiences, they might then go off the stuff for a little.
I think that's a different department.
That's a different area.
They both don't go together well. But yes, there are instances where ODs or others, friends dying and all those things are reason for people coming to the clinic as such, but they don't hate the substance or they don't get weird about the substance per se. There was a question from Dr. Chandran. Importance of smell. Sir, can you unmute yourself and ask this question? Like we couldn't get it. Yeah, please go ahead.
Importance of smell in identifying the agent consumed. It's not mentioned.
Not audible.
Hello. 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 Audible?
Yeah, smell can be of assistance to identify the substance. Like commonly, people with alcohol intoxication, it's easy to get through their breath smell, and whereas other substances like IV users and all, it's a little difficult to find out. But definitely for the cannabis users, alcohol to certain extent it is possible, as well as solvents too. Usually they are stained. The clothing is stained with this material, and a proper investigation. Observing could help in identifying the substance.
Are there any other questions from the audience here?
So thank you. I think we've had a fairly fruitful module overall and a fruitful discussion for today's ECHO program also. In the last 3 weeks, we have been seeing initially we got most of the topics in the current module has been, which are the topics which have been.
One question, last question which has come in. Sorry. Dr. Zillur had asked the role of blood level monitoring.
Definitely, so blood level monitoring is one of the way to identify and as well as which can be of assistance in management. For example, blood alcohol concentrations as well as even cannabinoid levels assessment. So this will definitely help us in assessing the severity as well as to proceed with the management.
Some of the objectivity, as of now, the objectivity in this thing, like the qualitative testing is the most easiest thing which is available in emergency, and to have a toxicology lab which would do 24/7 levels and give that for management, I think this setting hasn't improved. At least in India, it's one of the things which hasn't developed at all.
Also, contrary to the belief, urine levels are also found to be quite useful, and they tend to give us more prolonged results compared to blood levels itself. But of course, in acute states, blood level monitoring will be. Yeah. As I was trying to say, we have had fairly good discussions over the past 3 weeks, which are clinically relevant and will help us in further management. Thank you all of you for participating. Some of the partners have already left, but for all those who are existing, right now we will meet again next week for the again a didactic on suicide and a case presentation. Thank you all.